You all heard about bacterial biofilm for many, many years now. But fungi never remains very distant second. It has already started cropping up and it has become important. And in this aspect, I am going to really not giving you much solution because the problem has come, solution has yet to be found. But what is the exact problem and how we can think about for the solution I am trying to give it. First thing, regarding the definition of biofilm, we all know it's a microbial aggregate over abiotic or biotic surface. There is extracellular polymeric substance collection and it is usually associated with the infection. Now another terms have been coined along with this definition, that is there should be a resistance of these cells which are present inside the biofilm. Of course we know that is a tremendous cost which is there. Biofilm is found everywhere, wherever there is indwelling medical devices. Even in case of the chronic infection also, we find there is presence of this biofilm. So I am not going to this aspect details because you already know about it. But what happens in case of the fungal biofilm? Usually you know that the risk factors which you know in case of our fungal infection, systemic fungal infection, they are all associated similarly in case of the biofilm, like broad spectrum antimicrobials, neutropenia, parenteral nutrition, indwelling medical devices, etc., etc. In case of fungus, what now it is being believed, any fungus can produce biofilm. Whether you start looking at it, you will find that can also produce biofilm. But major discussion in case of you people who are working in ICU or critical care is mainly on the Candida and Aspergillus. Of course, Cryptococcus is one of the bug which produce very good biofilm because it is having a polysaccharide capsule which gets adherent very quickly. In case of Candida, you know, Candida and Aspergillus together, they have got 8% cases of indwelling medical devices infection and their survival rates is very poor, around 50% only. This is a long list of the usual indwelling devices which we use and the usage per year and the chance of infection of the fungi causing the biofilm. You can see from central and peripheral venous catheter to all these other procedures which we are doing. In all this there is a chance. And in this, especially in case of voice prosthesis, it has been found even up to 50 to 100% chance it is the fungal biofilm which is being there. And amongst the Candida, it is the albicans which is predominant. Though people really debate on this issue, they say that parapsilosis, because it is attached to the plastics, that's why producing possibly more biofilm. And what is the content where the biofilm usually is being there? These are already known slide, but just I am going to emphasize in case of the fungi again, latex is the worst material where the biofilm formation is the most, and silicone is the best which is known in case of the biofilm. Now amongst the Candida first, if I have to deal with, Candida albicans, we all know it is now the third leading cause of bloodstream infection and it is also having the second highest colonization to the infection rate. And overall mortality is very high. Though we know that Aspergillus or mucormycosis have got higher mortality, but sheer number of Candida infection in a hospital, it becomes the most important, having crude mortality in case of fungal disease. Non-C albicans Candida species, they also produce biofilm. It had been seen especially in presence of the more amount of glucose and during parenteral nutrition. Now comparing the Candida albicans and non-albicans, people used to believe that the Candida albicans produces the maximum biofilm, but there are few papers you can see where parapsilosis has been said to be producing more biofilm. So I am not going into the debate. It is just you want to see which one in your hospital is producing more invasive infection and causing the biofilm. Now the biofilm can occur, especially in an indwelling device, by contamination at different level. It can be contaminated in fuse set itself, it can be a contamination of the catheter hub itself, or their skin organism which is going inside on contamination of the device prior to the insertion. Whenever the Candida producing the biofilm, they first start multiplying. And these are the yeast cells which multiply, then they produce pseudohyphae and hyphae, and slowly they mature, and following maturation, they produce the extra polymeric substance, which is the main content of the biofilm making the aggregation. So in case of in vitro, when you try to develop biofilm in the lab, there is some difference had been seen. In the lab, we see there are very distinct layers. Below there are yeast cells. In the top, we see more of the hyphae. But in vivo biofilm, both these cells are found to be in mixture condition. This is, I know you are all mostly clinician, but the genetic control of the biofilm is becoming very important. The reason is, if we understand this aspect, you can think about which is the way you can intercept the biofilm. Because if you see this slide, here in case of adherence, these are the defined proteins which are getting responsible, and these are the defined genes which are getting stimulated. If we have the understanding of this aspect, at least those can be intercepted in case of the biofilm, either in case of adhesion, or in case of the maturation, or in case of the dispersal. Aspergillus fumigatus, the picture is a little more interesting. You know, Aspergillus produces aspergilloma, either in case of preformed lung cavity or in case of your sinus cavity. It had now been seen that these are biofilms. This aspergilloma or the fungal ball formation is biofilm. And if you look into in vitro condition, they produce similar biofilm like in case of the Candida. But this is that particular interesting study which had been done by the Institute of Pasteur, which had shown that there is presence of extracellular matrix which is being present surrounding the fungal hyphae in case of this when there is formation of the aspergilloma. And compared to this, if you see in case of the invasive aspergillosis in case of the animal, the content of this material is far less. So this is very interesting that in live condition we can have this biofilm which is ultimately forming the fungal ball formation. As I said at the beginning, any fungus can produce biofilm, but there is no knowledge about in case of zygomycete or the mucormycotic agent producing biofilm. But you know, in our country, we are possibly the capital of mucormycosis because we have got the highest incidence throughout the world. And in this case, they can have similar type of infection as in case of aspergillus. And as there are some case reports where we had seen that there is a chance of CBC and drainage catheter where there is infection. There is peritonitis in case of continuous ambulatory peritoneal dialysis. Also, we see in case of mucormycosis, mucor also can produce endocarditis. So, in our lab, we tried to look into whether zygomycetes can produce biofilm. We used the four main agents which are seen in case of the India, that is the Rhizopus aerugis, the Lichthemia corymbifera, which is earlier named as Absidia corymbifera, Rhizomucor pusillus, and Apophysemis elegans. I am not bothering you with the names, but what I like to emphasize, there is differential biofilm formation which you could see. And this is the biofilm which you could see in our lab, and you can see in case of fluorescent, especially with the WGA, we could see that there is N-acetyl glucosamine present inside the biofilm. That's why it is making such a complex structure, whereas in Corne, which is more stimulating or attacking the polysaccharide, that is not being much present. By this process, we could identify in case of zygomycetes what is the matrix substance which is producing the biofilm. So if you look into the matrix composition wise, there is difference in case of the aspergillus, in case of the candida, even amongst the species. You may ask me why you are saying all this to the clinician. You know, these are important because these matrix component is the most important factor while the drug penetration. So what is the matrix component would be much bearing when you are giving the drug. In case of Aspergillus fumigatus, monosaccharides and polysaccharides both are seen. In case of monosaccharides, mostly it is the glucose or mannitol which has been seen, or in polysaccharide, in case it is the glucan or the galactomannan had been seen. Whereas in case of Candida biofilm, it is more of glucose and hexosamine. And here you can see that the species-wise there is difference. Candida tropicalis has got different component from the Candida albicans. And when we look into our zygomyces biofilm, we found it is more with the N-acetyl glucosamine. Now, there can be polymicrobial biofilm, that is bacteria and fungus both together may produce biofilm, and 25% biofilm have been found to be polymicrobial. But here also there are very interesting facts. There are symbiotic as well as antagonistic interactions that have been looked into. Like C. albicans, it produces some quorum sensing molecule which is called farnesol. This farnesol that inhibits bacterial biofilm formation. So if we have farnesol, you can possibly use it inhibiting the bacterial biofilm. Similarly, opposite had been seen. Pseudomonas aeruginosa, they produce acyl homoserine, and this acyl homoserine, they inhibits Candida biofilm formation. Now, clinical relevance of the biofilm is that it causes resistance to antifungal, it causes resistance to the immune response, and whenever there is detachment, the dispersal produces multiple infection at different sites. This one paper would be sufficient to emphasize, because you all know that biofilm is a major important factor in critical care. You can see the biofilm production is being associated significantly with more mortality compared to the non-biofilm formation. Now, this antifungal resistance which is produced in biofilm is nearly 30 to 2,000 times, and that's why it is very difficult to treat, and this problem is more in case of eukaryotic pathogen. Though it's a busy slide, just I like to emphasize that compared to these MIC in case of the biofilm cells and the planktonic cells, you can see more than hundreds or 1,000 times, which is more MIC compared to the planktonic cells. Now, the question comes, why are biofilm resistance? It's a multifactorial fact. There is phenotypic and genotypic response, both have been seen. Relative contribution has been seen with the type of the antifungals and the type of the microbes, and there is impact is so much that it has now been included in the definition of biofilm formation. So, in case of development of resistance, what may be the reasons? One is that the extra polysaccharide, this is the extracellular polymeric substance that prevents the penetration of the drug. It may be one reason. Slow growth might be the factor. Spatial heterogeneity might be factor. Drug tolerance phenotype may be factor, or drug efflux pump may be the important factor, and increased stress response may be the important factor. Take this case of the reduced antifungal penetration. You know already, this is commonly known that this is preventing the entry of these antifungal compounds, but some compounds like fluconazole and flucytosine still can penetrate better. Antifungal drugs act on active cells. The biofilm cells are slow grower. That's why there is a chance of another reason. This is one slide which can very clearly mention how with the maturation the MIC increases in case of the biofilm. But there are contradictory reports. Like in case of Candida biofilm, it has seen that the basal cells which is getting less oxygen, it may be metabolically active, and azole is effective under anaerobic condition. That consists of these persister cells. Persister cells are one of the population 1.1 to 10%, which is not genetically resistant, but they have got defective apoptosis and they have maintained the dormant state. You can see this particular experiment which clearly says that initially when the antibiotic or antifungal given, there is a decreased cells, but when the persister cells come, it cannot work. So there is a resistance which has been seen. So you can see in the maturation how the persistent cell population are increasing. So these persistent cells are increased in number compared to the planktonic phase, and they are protected from the immune response because of this, again, this polymeric substance, and there is a difference in presentation in case of persistent amongst the different species. And you can see there is another factor is the drug efflux pump. And drug efflux pump is either multifacilitator component or this is the ABC transporter system which is there, which is responsible in case of the Candida albicans, whereas in fumigators it is more with multiple facilitator. Especially this is active during the early phase. So you can see how this drug expression is more as the biofilm is maturing. Whenever you are giving a drug, there is an increased stress is there for the cells which is being present. And this stress has also been seen that if the fungus cell are present inside the biofilm, they can avoid this stress mechanism. I am not going into the detail of it, but what important, it has been seen also that ergosterol biosynthesis is being showing to be lower during the late phase. And the ergosterol where the azole compounds work, if it is low, then there is a chance of more resistance. Just lastly showing that if we have to show the resistance, how it can be done. This is one protocol which all microbiologists know, that is the XTT dye reduction test. But what we developed a new technique that is being used quite nicely in our laboratory. We developed a Muller-Hilton agar where we have put the test cells on which we put the biofilm and over the antibiotic disc is there. If this antifungal drug can penetrate through the biofilm, it will work on the test cell. If it cannot, it would not work. So when we compared the different types of Candida cells, we found that with the different drugs, the test versus control, there is significant difference. But what we found that in case of, at least in case of echinocandin, that can penetrate better. That's why there is no difference between test and these cells. So what are the therapeutic options? Of course, there are many therapeutic options. These are the last two slides, removal of the IMD or systemic antifungals. People say echinocandins and liposomal amphotericin B are better, but you need to look into it. And there are several claims among the different studies that amongst the three echinocandins, some are better. But what I believe is that there is no difference amongst these three echinocandins regarding its action for biofilm formation. And you can also do the photodynamic therapy, and there is also some other compound. As I have said that you can use the farnesol or homoserine because these are the compounds which can be utilized in case of inhibiting the biofilm. So what I said is that fungal biofilm is important, and of which the candida is the predominant. These are implant associated and also chronic infection, and it causes antifungal resistance increase. There is multifactorial fact is there. Limited therapeutic options still we have, so we need further studies whether it is regarding how the mechanism occurs or what is the different interactions. Thank you for your kind attention.